I'll just be covering diabetic retinopathy, not cataract with it. So just a few pointers. We know that diabetes is now, rampant in our country and over the world. If diabetes was a country, it would be the third highest populated country in the world. In India, 20% of all diabetics would have some amount of diabetic retinopathy. And the important thing to note is that after 20 years of having had diabetes, a type 1 diabetic would have almost 100% diabetic retinopathy. And in type 2, the prevalence would be around 60%. So 60% of all diabetics after 20 years having type 2 would have some amount of diabetic retinopathy. So it's extremely important to recognize and manage this condition appropriately, because a diabetic has a 20 times more chance of becoming blind as compared to a non-diabetic. Now, whenever you see a diabetic patient and you see retinopathy like this, the first thing is to ask the patient to get his baseline examinations, the blood sugar, the blood pressure, and the lipid profile. I would also like to add hemogram to this, because anemia is another, uncorrected anemia is another cause of increase in retinopathy. So these are the parameters that you would aim for. And HbA1c, many patients will say, "Hamari sugar controlled hai," but when you ask them to get an HbA1c, it would reflect the true picture. So every diabetic, do ask them to get an HbA1c. And this is with systemic control alone. You see all the lesions have disappeared after 1 year because the patient came back with good control. Now, a follow-up of diabetic patients, this is the follow-up schedule. So annual follow-up if the patient has no retinopathy. For a mild retinopathy, every 9 months. For a moderate NPDR, would be everywhere. You just have a few microaneurysms scattered here and there, would be 6 months. Severe NPDR, where you would have microaneurysms, hemorrhages in all 4 quadrants, would be every 2 to 4 months. If a patient has macular edema, then 2 to 4 months. For a PDR, again, a close follow-up is needed. And once you've treated a PDR, then also every 6 monthly or annual follow-up is very important. So a patient with diabetic retinopathy, you should always do an OCT, except when you feel that the fundus is absolutely normal. But otherwise, whenever there are any lesions, an OCT is imperative to identify the macular edema and also to identify vitreomacular interface abnormalities, which you would very commonly see in these diabetics. Now, most of the times, only OCT, I mean, we all do OCT has become the diagnostic instrument of choice. But an angiography would help you to detect the areas of capillary dropout, to know how much ischemia is there, to identify any new vascularization, something that you cannot identify with your naked eye, and also to detect the ischemia at the macula. That is a very large or distorted FAZ would give you a hint to the visual prognosis of the patient. So this is a patient of ischemic maculopathy, and you see when you've done the angiography, you see that there is hardly any circulation over here, and this is a patient who would not get good vision in spite of all your treatments. Also on OCT, whenever, like I mentioned before, whenever there's any disruption of the ellipsoid zone, these are the patients who would have a poor visual outcome. Also drill. So drill is a disruption of the inner retinal layers. So here you see all the retinal layers. You cannot make out those different lines in between the retinal layers here in the central part. So that is called drill. And again, drill is a negative prognostic factor. So once you do an OCT and you get all these features, you have to inform the patient that I'm going to treat you, but do not expect a very, very great, increase in your vision. Now, the definition of central, we all studied about CSME, and this definition has now evolved over time. And now the definition requires the foveal center to be involved. So this was the CME, this was the definition, the classic definition of the CSME that we studied. But now we speak in terms of central involving and non-central involving diabetic macular edema. So this is the only part of the CME that comes in the central involving, that is an area of retinal thickness within 500 microns of the fovea. So this is central involving, and anything else apart beyond 500 microns would be non-central involving. So if the edema is non-central involving, that is away from the fovea, then laser still has a place in the treatment of these patients. So here you see non-central involving edema, you could do a laser. This laser could be focal, where you only laser the microaneurysms, or it could be a grid laser where you do a mild laser to the entire thickened area. And in macular edema, non-center involving is one indication for laser. For a center involving DME, the treatment of choice is injections, anti-VEGF injections or steroid injections. So generally we would start with anti-VEGF injections. You could give 3 monthly injections and then give them as and when needed. There are different treatment protocols. There's no standardized protocol. Every surgeon has his own way of treating these patients. You could give them as and when needed. You could do a treat and extend regime, or you could give 3 injections monthly in the beginning and then follow them up. So this is a patient pre-injection and post-injection. We now have so many anti-VEGFs in our armamentarium. The stronger anti-VEGFs like Eylea and Vabysmo, the new generation anti-VEGFs, they work much better and have a more sustained effect. You could also do a combined approach in patients who are not resolving, where you give them anti-VEGF and then do a bit of laser. So sometimes you may not have as good an effect with one anti-VEGF, and that is the time you switch anti-VEGF agents. In patients who have a very large edema or a chronic edema with large cystoid spaces, steroids work excellently in them. And also patients who are not responding to anti-VEGFs, or you feel would not have a very good follow-up, then dexamethasone implant works very well for those patients. When to stop injecting, either the vision improves or the foveal contour returns to normal and you see no thickening, there's disappearance of the cystoid spaces, or there is no further improvement. That is, there is no further decrease in the central subfield thickness and there's no visual gain. Now, once the patient is not improving, you can just follow up the patient. A small amount of fluid sometimes can be tolerated. And, but these patients have to be closely monitored every 3 months and inject whenever the vision goes down or the edema increases. Now, whenever you see a patient with severe NPDR, that is, a patient does not have new vessels, but he has hemorrhages, microaneurysms in all the 4 quadrants, venous beading, venous looping. So these are the patients that you have to follow up very closely, because a lot of these patients will develop PDR in the next 1 year, so you have to follow them very carefully. Now, in severe NPDR, there is always the question, should we laser these patients or not? If you feel the patient would not be able to come for a follow-up, also is pregnant, then you can subject, or is not very well controlled, you can subject these patients to a laser photocoagulation. And, for a proliferative diabetic retinopathy, like always examine the patient with an indirect. So if you see the patient on 90D or a direct ophthalmoscope, you see this is the central area which appears absolutely normal. But here you see that the patient has a proliferation. So an indirect examination is extremely important in all diabetics. Also, patients would come with floaters or cobwebs or streaks, and sometimes you will not be able to see the hemorrhage, but if you look inferiorly, always examine the inferior quadrant very well, because there you'll see sometimes very subtle hemorrhages. And all hemorrhages in a diabetics does not equal to a neovascularization. Many of the diabetics have a PVD, and the vitreous is very sticky in these patients. So PVD can also induce hemorrhages in these diabetics. And not all hemorrhages doesn't equal to a neovascularization, and you can do an angiography to confirm. So these are some pictures of a PDR. Now, for a proliferative disease, laser is still the gold standard. You can give anti-VEGF injections in some subset of patients, or you can give anti-VEGF along with laser, but laser is the one which works for a pretty long time. And laser you have to do in multiple sittings. Do not do all your laser very aggressively at the patient, otherwise the patient will come back with complications like exudative detachments, choroidal detachments. So this is a picture pre-laser, and you see post-laser, the new vessels have disappeared. Like I said, the laser should be done away from all these areas or the fibrous areas. Never do your laser very close to these. You always keep a margin. Otherwise, when these regress, they could cause a break in the retina. Now, another question that is very frequently asked is that when a patient comes with vitreous hemorrhage, should we give him anti-VEGF injections or not? So a patient with vitreous hemorrhage, the anti-VEGF injection is not going to make the hemorrhage go away, but it will prevent further rebleeds. So this is what you have to tell to the patient. And before injecting, it's very important to rule out any traction. So you can do an ultrasound. If you can see through that hemorrhage and you see that there's no traction, only then should you inject an anti-VEGF. Otherwise, do not inject anti-VEGF because it can cause a crunch phenomenon. It can cause that traction to increase. Sometimes it can also cause breaks in the retina. Another question is that whenever there is PDR with diabetic macular edema, what should we treat first? So always treat the macular edema before doing your pan-retinal photocoagulation, because if you do photocoagulation before, then the macular edema could increase. So ideally, you should be treating the macular edema before you do your laser photocoagulation. Patients who are not amenable to laser, so these are the categories of patients, like patients who have a large vitreous hemorrhage which is not resolving. They have PDR despite your lasers and your injections, the PDR is still persisting. Whether there's a tractional retinal detachment at the macula or near the macula, a combined detachment, or vitreous hemorrhage along with neovascular glaucoma, these are the patients who should be taken in for pars plana vitrectomy. So these were just some, diabetic retinopathy is a very, very vast topic to be covered. I've just tried to cover a few common questions and given you a few pointers, and I'd be most happy to take questions. So my final points are that metabolic control is very important. For a macular edema which is central, anti-VEGFs are the treatment of choice. For a non-central, laser, you can still do laser. A severe NPDR, you can laser, provided if you feel that the patient will go into proliferative stage, it cannot come for follow-ups. For a PDR, pan-retinal photocoagulation combined with anti-VEGFs can be done. And whenever there is a tractional detachment or a non-resolving hemorrhage, then vitrectomy is the treatment of choice. And also systemic control is extremely important. Thank you.
Thank you, Dr. Tinku, for a very extensive topic you have covered in 8-10 minutes, and I hope everybody must have taken a few take-home points. Any question from the audience?
Hello. One question is there, myself. You said that less than 10% decrease in subfield thickness is an indication for stopping anti-VEGF. So after what number of injections we should stop? After three? Or we have to see on PRN basis?
Generally, when you've given 3 injections, you've given 3 monthly injections, and you feel,
whatever the anti-VEGF may be.
Whatever the or you've switched the anti-VEGF, and still you're not getting a good response. The patient still has maintaining that same edema after switching also. So it's not that you have to have a completely. What I meant to say was that many a times you will not have a completely dry macula, but if the patient is maintaining his vision and you feel that little edema is not going down, you can follow up the patient also.
Thank you.
That's what I meant to say.